Tucked deep in the retroperitoneal cavity, sitting directly on top of the kidneys, are the adrenal glands. They are small, structurally complex endocrine organs that frequently develop mysterious, incidentally discovered masses. The anatomical baseline for these paired glands is distinct. The right adrenal is roughly triangular, while the left typically assumes a more elongated, crescent shape. Their vascular supply is highly redundant on the input side, drawing arterial blood from three separate sources: the superior phrenic, the middle aorta, and the inferior renal artery. However, this funnels into a single venous drainage path, emptying directly into the IVC on the right and the renal vein on the left. Physiologically, the gland is divided into two distinct factories. The outer cortex produces aldosterone, cortisol, and androgens. The inner medulla manufactures catecholamines. Up to 8% of the general population has an asymptomatic mass growing in one of these zones. This high prevalence creates a massive diagnostic burden for radiologists, who have to determine which masses are harmless and which are lethal. The method for solving that problem completely bifurcates based on the patient's age. For pediatrics, diagnosis relies almost entirely on the qualitative shape and texture of the gland on ultrasound. For adults, the pathway relies on rigid, quantitative math derived from CT scans. Managing an adrenal incidentaloma relies on precise applied physics and age-dependent imaging protocols, which often removes the need for immediate surgical biopsy. In pediatrics, ultrasound is the primary modality. It avoids ionizing radiation, and neonatal tissue has a unique echogenicity that makes high-frequency sound waves incredibly effective for mapping internal structures. The fetal adrenal gland is comparatively massive. In the second trimester, it is half the size of the kidney. By adulthood, it will shrink to 1/13 the size of the kidney. This schematic displays the morphological baseline of a neonatal adrenal gland on ultrasound. It forms a distinct, high-contrast Y shape. The visual signature is the triple stripe. The outer dark bands represent a hypoechoic cortex, perfectly sandwiching the central bright hyperechoic medulla. Because the adrenal gland forms in strict proximity to the kidney, an embryological interruption alters its shape. If a patient has congenital renal agenesis, meaning the kidney never formed, the adrenal fails to form its Y shape. Deprived of support, it elongates into a flat line. A second anomaly occurs when the limbs of the two separate adrenal glands fuse across the patient's midline, creating a horseshoe adrenal gland. This specific fusion is highly associated with larger systemic syndromes, most notably right isomerism, presenting with an absent spleen and severe congenital heart disease. Recognizing the precise geometric distortion of the pediatric adrenal gland gives the radiologist the first indication of much broader, systemic embryological failures. Beyond congenital absence or fusion, intrinsic glandular pathologies also present with specific structural distortions. The most critical is congenital adrenal hyperplasia. Driven by a 21-hydroxylase deficiency, this condition manifests clinically with genital ambiguity or as a life-threatening salt-losing crisis in newborn boys. On ultrasound, the primary diagnostic threshold is dimensional, a gland length exceeding 20 millimeters and a lymph width greater than 4 millimeters. This animation shows the visual distortion characteristic of the hyperplasia. The gland enlarges, the surface wrinkles into gyri and sulci like a brain, and the central bright stripe vanishes. The entire structure adopts the dark, hypoechoic appearance of the overactive cortex. This wrinkled brain appearance clearly contrasts with the most common stress-induced anomaly in neonates, an adrenal hemorrhage. Hemorrhage is classically triggered by physical perinatal trauma, such as a breech birth. The result is a massively enlarged gland dominated by an anechoic, fluid-filled component where the blood is pooling. A simple series of follow-up ultrasounds solves the diagnosis. An actively clotting hemorrhage will physically shrink over time. A cystic neuroblastoma, the primary malignant mimic, will not. By tracking the internal echogenicity and size of the mass over time, the radiologist separates a life-threatening endocrine crisis from a naturally resolving birth injury. In adult patients, the methodology shifts. We discard qualitative ultrasound shapes and rely entirely on the quantitative physics of computed tomography. The diagnostic dilemma remains the high prevalence of adrenal masses. The statistical probability is that the mass is a benign adenoma, but clinical guidelines dictate this must be rigorously proven. The tool for this is the Hounsfield unit, the absolute metric of radiodensity. Because X-rays pass through different materials at different speeds, fat registers at a drastically different Hounsfield unit than soft tissue. Benign adenomas are categorized by the amount of microscopic intracellular fat they contain, dividing them into lipid-rich and lipid-poor groups. This slider tracks radiodensity. The absolute baseline rule for adult imaging is a hard cutoff at 10 Hounsfield units. Any mass measuring less than 10 HU on a non-contrast CT contains enough microscopic fat to be definitively classified as a lipid-rich adenoma. The diagnostic challenge arises when the mass is lipid-poor, yielding a density above 10 HU on the initial unenhanced scan. The sub-10 Hounsfield threshold is a direct mathematical shortcut. It entirely eliminates the need for surgical biopsy simply by proving the presence of intracellular fat. When a mass registers above 10 Hounsfield units, the radiologist must administer intravenous contrast and track how blood flows in and out of the tumor across multiple time intervals. The physiological premise here is known as washout. Benign adenomas are highly porous. They absorb contrast quickly, but flush it out just as fast. Malignant tumors, with their disorganized cellular structures, hold on to the contrast. To calculate this, the CT scan is performed in 3 distinct phases: unenhanced, a portal venous phase representing peak absorption, and a delayed phase taken exactly 15 minutes later. This graph plots the attenuation over time. 2 mathematical formulas prove the mass is benign: an absolute washout greater than 60% or a relative washout greater than 40%. However, these formulas contain a critical trap. The washout math is invalid if the tumor exhibits extreme hypervascular enhancement. As a mass reaches a peak attenuation greater than 120 Hounsfield units, it cannot be classified as an adenoma. 2 primary pathologies cause this hyperenhancement: hypervascular metastases from the kidney or liver, and the pheochromocytoma. The pheochromocytoma is a catecholamine-secreting tumor known for its rule of tens, meaning 10% are bilateral, 10% are malignant, and 10% are extra-adrenal. It is also strongly associated with the MEN2 syndrome. Because pheochromocytomas frequently mimic the rapid washout patterns of benign adenomas, checking peak enhancement against the 120 HU limit is the only mathematical safety net. Rapid contrast washout confirms a benign architecture, but monitoring the extreme limits of contrast uptake exposes the hypervascular mimics hiding in the math. When attenuation math fails to provide a clear answer, diagnosis shifts to macroscopic dimensions and the size heuristic. Overall dimension strongly correlates with the probability of malignancy. Masses larger than 4 centimeters carry a 70% chance of cancer. Over 6 centimeters, that probability climbs to 85%. The major benign exception to this rule is the myelolipoma. These tumors can grow to massive proportions, but because they are composed entirely of bulk fat, they present no malignant threat. On ultrasound, bulk fat causes the discontinuous diaphragm artifact. Sound waves slow down when hitting a myelolipoma. Because depth calculation assumes a constant speed, the delayed echoes map underlying structures deeper than they are, making the solid diaphragm line appear physically broken. The myelolipoma must be carefully distinguished from the truly dangerous large mass, the adrenal cortical carcinoma. Carcinomas typically present larger than 5 centimeters, completely lack bulk fat, and feature central necrosis alongside direct invasion into surrounding tissues. Size serves as the most reliable proxy for malignancy, but understanding the specific acoustic physics of bulk fat ensures that a massive, benign deposit isn't mistaken for a lethal carcinoma. The complete diagnostic landscape for the adrenal incidentaloma requires a strictly age-dependent triage tree. In pediatrics, the pathway tracks morphology. Radiologists look for the normal triple stripe, noting if it flattens from agenesis, wrinkles into a brain shape from hyperplasia, or swells with anechoic fluid from a hemorrhage. In adults, the pathway is one of mathematical exclusion. Benignity is proven by establishing a non-contrast density below 10 Hounsfield units or calculating an absolute contrast washout greater than 60%. At every stage, protocols must be cross-checked against the hyperenhancing pheochromocytoma and the massive necrotic cortical carcinoma. Pediatrics relies on structural pattern recognition. Adult imaging demands a rigid algorithm of exclusion. Definitive diagnosis of the adrenal incidentaloma is achieved through the rigorous application of imaging physics and algorithmic discipline.